My name's Kevin Knoblock. I'm one of the nurse practitioners at Mass General Hospital in our Crohn's and Colitis Center, where I spend pretty much all of my time dedicated to our Crohn's and ulcerative colitis patients. And I put together a little bit about differential diagnoses, to sort of get us to help think about, what else do we think of, what do we see in clinic that, might mimic symptomatically IBD. So we could spend a ton of time on differential. So I kind of picked a handful of them that I see pretty frequently. This is the first time I'm giving this presentation, so please bear with me. Um, Microscopic colitis is going to be one we'll go over quickly. Infectious colitis, which is a big umbrella term, chronic mesenteric ischemia, celiac disease, IBS, which is huge. I don't think there's a human on the planet who hasn't had a touch of IBS at some point. Diverticulitis, and then something we're seeing more and more here for a bit. So immune checkpoint inhibitor induced colitis. So, okay, just a quick, I know a lot of people on this call are, approaching, coming from different parts of their career, fresh out of school, a little bit longer, you've been in GI, just some things I've seen, especially more on the newbie side. Make sure you know symptoms versus your diagnoses. Like sometimes I've seen someone says, oh, a patient was diagnosed with diarrhea. And I'm like, well, diarrhea is not technically a diagnosis. It's a symptom of something else that's going on. So just a little, reminder for, so you look really, 100% when you're at those sites. So microscopic colitis, the first one. This is a chronic inflammatory disease of the colon. And it does affect the lamina propria and the surface epithelium, sorry, and have a little diagram over here, so that inner layer right there. And then there's two types of microscopic colitis: lymphocytic and collagenous. An important thing here is the median age of microscopic colitis. It's like a 60 to 65-year-old. We see a lot of the diagnoses, fewer than about 25%, under the age of 45. So, as you just heard earlier, like the mean diagnosis of our IBD patients are definitely skewing a little bit younger than that, in the 15 to 30 age range is the peak. More females, in a bigger academic center, we might see AFAB, which is assigned female at birth, assigned male at birth. So females greater than males for collagenous colitis. Non-steroidals seem to be a pretty big, maybe trigger of a flare of microscopic colitis. And also predisposing are proton pump inhibitors, statins, SSRIs, H2 receptor antagonists, and even smoking. So next slide. So the symptoms. What do we see with sort of a microscopic colitis presentation? Definitely increased bowel frequency, at least 3 times per day, but it can be a lot more. This is going to be probably more sudden onset than maybe a Crohn's ulcerative colitis patient, depending how hard it hits them as well when it first comes on. There'll definitely be bowel urgency. They might have some abdominal cramps because if that stool is a bit looser, it's just kind of wanting out, and they just going to maybe have a little bit of urgency to run to the bathroom. Nocturnal bowel movements are not uncommon as well. That looser stool, like we just can't hold it in as easily, and it wants to come out. They've even had incontinence. You'll hear people, they can't even get out to the store, do their errands, and they're unfortunately sort of leaking stool, especially if they have some gas. Weight loss, not entirely hugely common, but they might be eating a little bit less because they realize the more I eat, the more I have to run to the bathroom, and I really don't want to have to do that, and it's hard to get outside the house. So this is where I try to, for each of our little diagnoses, I wanted to sort of separate like the generic symptoms that might be common to IBD plus the differential. It blood and stool. Are we going to see blood in microscopic colitis? No, we should not by any means. Maybe there's some trace blood. If they're having multiple bowel movements, they're, seeing some trace on the paper. Maybe they even have a hemorrhoid. So this is, I always don't forget the art of medicine. History, history, history. Make sure you're digging, asking all of those questions, because they might just say, oh yeah, I see blood. And like, why are we seeing blood? What's going on? Obviously, definitely more common in ulcerative colitis to see blood. You might see some Crohn's blood, depending if it's, very distal in that last part of the terminal ileum, if there's some, ulceration going on. Abdominal pain could technically be, probably most likely be a little more severe in IBD. Again, depending, how fulminant is the disease. Is it really active or is it just the beginnings of it? as you'll see, like IBD can take a while to declare itself. Sometimes we don't know what it is for quite some time. Low-grade fevers, definitely, I think, as we heard, are a little bit more common in the IBD population. Shouldn't really see them in microscopic colitis. The mouth sores, joint pain, skin rashes, eye issues. I won't spend a ton of time in, but they are great questions to ask. You have a whole talk on this a little bit later. So that's something that will differentiate your IBD patient from all others. Okay. So again, some of the extraintestinal manifestations, just to go over them quickly. So arthritis is sort of a big one, joint pains, derm issues, eye issues, and hepatobiliary. I don't think I have an additional slide, but sort of we'll see some narrowing of the bile ducts in the liver. So I just put some quick photos in here. So the derm sort of ones are like oral ulcers right here. A lot of people say, "Oh yeah, I've get these, lip sores." That's definitely more of an HSV1 presentation, not more of an, aphthous ulcer. Pyoderma is pretty ugly looking, as you can see it here, and then erythema nodosum. Very common. And the erythema nodosum tends to be a little bit more associated with active intestinal inflammation. Last one, ocular. So uveitis, scleritis, episcleritis, all sort of inflammation going after the eye. So a big thing to ask a lot of patients, all of these questions are: have you had eye redness, eye pain, the joint pain? Have you noticed, skin rashes, and do they correlate with your GI symptoms? Again, we shouldn't see these things with microscopic colitis. These are a little bit more, unique to the IBD population here. Okay. So microscopic colitis, it's presenting like diarrhea, sort of an acute diarrhea. It comes on pretty quick for a lot of people. So you're going to do that standard acute diarrhea workup. You're going to get labs. CBC, usually pretty normal. The CMP might show some dehydration, etc. In there. Your CRP, ESR could be a little bit elevated because it is an inflammatory process of the colon, and we can see an elevation of it there. Your vitamin D, B12, folate usually are going to be normal, but they could be a little bit low just because this is sort of, a chronic inflammation that's going on. And I won't get into the pathway, but it can lead to some of these deficiencies, but usually not. And iron as well, maybe some mild anemia. Again, if you're thinking about diarrhea, is celiac, maybe an issue too. You check a serum IgA and a TTG as well. You can get a calprotectin, which is a lot more common test these days. 10 years ago, 15 years ago, we weren't using that as much. The unfortunate nature, as many of us might know, a calprotectin, at least here at Mass General, does not come back immediately. We're waiting 5 to 7 business days to get that back. But it can be elevated again because of the inflammation in the colon. And of course, if you're getting stool, just get the culture, C. diff, etc. And again, in microscopic colitis, this should be negative because there's no infection driving this diarrhea. Colonoscopy, you're not going to get that probably until a little bit later once you're more down the chronic diarrhea and you've kind of ruled everything else out. Nothing else is really showing up. And it will look normal. It will look normal. The attending physicians that will be doing these scopes, make sure in your note or you're communicating that, you have a concern for microscopic colitis because, they're not going to see anything. So they're going to need to do some random biopsies. So pathology right here is sort of where it's all going to be at. So for lymphocytic colitis, you're going to see this increased number of intraepithelial lymphocytes and then no significant thickening of the subepithelial collagen layer. But in collagenous, you'll see this thickened collagen band, and technically our pathologists will give us sort of a measurement, and it should be greater than 10 micrometers. So this is where you're going to get, your information sort of for microscopic colitis. Imaging, you're probably not thinking about CT, MRI at that point because there's probably not much weight loss. There's usually not really like abdominal pain, not the combination of all of that. So, but if you did get an MRI or if you show up in our emergency department here at Mass General, most people do get a CAT scan, unfortunately. You're not going to really see too much because that inflammation is not really, extreme by any means. Okay. So the next one, infectious colitis. Again, this is sort of an umbrella term. It could be a number of pathogens. I just threw some here, some of the more common ones. I can't believe last week I saw an E. coli and a salmonella. I haven't seen some of these in a long time. They could be viral, they could be bacterial, they could be parasitic. Again, this is really going to, present to you like diarrhea. And diarrhea is very common again to Crohn's, ulcerative colitis. The risk factors for sort of an infectious colitis, the foreign travel. Actually, the salmonella I saw last week was a young guy coming back from South America. Recent hospitalization, or if you've been in a rehab, patient's been in a rehab facility or work even in that setting. Recent antibiotic use, we know, probably is very C. diff sort of oriented. People who are immunocompromised, if they're on other meds for some reason. A little bit on older age too. And then sort of the difficult one sometimes to ask is sort of unprotected receptive anal intercourse for sort of the sexually transmitted infections in the colon, chlamydia, gonorrhea, etc. So again, the symptoms, sort of similar again. This is diarrhea, diarrhea, diarrhea. It's going to really kind of hit them like a train, probably. Actually, I did pick up C. diff on our inpatient floor, and it hit, and it came out like a faucet. There was really no pain, but it just would not stop. And again, it can vary on the severity of how bad the infection is. Again, and it's an acute onset. Definitely urgency, I can attest to. Could be definitely blood. You can see it more in your E. coli, salmonella ones. Definitely some abdominal pain, although did not happen with me. Fevers can be high if this is a bad infection going on. Nocturnal bowel movements, definitely. Sometimes people are going 10, 15 times a day and not much really will stop it. Incontinence as well. That tenesmus feeling like I've got to go to the bathroom. Sometimes not much has come out because they'll have just gone and then they feel like they have to go back again. And general nausea, vomiting, just because you don't feel well at all. So maybe some of the differentiating symptoms here to sort of look out for. We'll see pretty high fevers in like an infectious colitis. The diarrhea can be more acute and severe. Although if they are in a really full UC flare, if you're just like monitoring them, which most of my patients, I'm just monitoring them or attending, see a lot of the new ones, but they can get some pretty severe diarrhea if they're in a massive flare. But if you're seeing sort of new general GI patients and this hasn't declared itself yet, it can be a very different picture. It can be at the very beginning, but this infectious colitis will usually ramp up really quick. And again, the severity of the abdominal pain really can, again, history, history, history. And again, don't forget to, it could be helpful, to ask about mouth sores, those skin rashes, the joint pains, the eye pain, and the eye redness as sort of those distinguishing sort of symptoms for the IBD patient. Okay, again, more diarrhea, as we've said. Doing your labs, your CBC might be, the white blood count, probably will be elevated. This is an infection. Your CMP, your creatinine, obviously probably going to show some just signs of dehydration overall. The CRP, ESR blood test can definitely be elevated as this infection is, could be causing a colitis going on. Calprotectin definitely can be elevated as well. Again, can take some time to get that test back. And then again, stool, you're doing the culture, C. diff, even maybe ovine parasites if they've really traveled abroad or something like that. That's where you're going to get your results as sort of, you're going to get a positive test and, take care of whichever it is there. Again, you're probably not thinking endoscopy because, if this is an acute diarrhea presentation, that's not first thing on your list. The stool studies will come back, pretty quick and positive before you'd probably get them on for an endoscopy. You know, if you do a colonoscopy, some of those findings might mimic a little bit of an IBD UC looking. There might be some inflammation going on in there because of the colitis that was triggered by the inflammation. Imaging, again, probably not warranted as this is more of an acute phase, and it's not going to change management for sure. Again, if you did get, an MRI or CT, usually CTs in the ED, as they're just quicker to do, you could see this sort of contiguous distribution of colonic wall inflammation. So could mimic a little bit if they hit your ED and etc. Okay. Next one, chronic mesenteric ischemia. Threw that on there because it could kind of mimic a little bit more of maybe some Crohn's disease-like symptoms. So this is just a reduced blood flow to the intestines. Could be due to plaque buildups, clots, blood shunting, like marathon runners. You might have heard stories. Marathon runners are like run, run, run. But they definitely get more of an acute ischemia, and that has different symptoms. But that's kind of the overall sort of process there. So patients we see who get chronic mesenteric ischemia, they're definitely 60 plus. Females almost 3 times as males, as some of the data showing. Smoking, 50% of people who've smoked have a risk for seen with mesenteric ischemia. Coronary artery disease, diabetes, elevated lipids, and obesity. So it's kind of, sort of coronary artery disease for the gut here. As you can see, we get you have your inferior and superior mesenteric artery that sort of feed the blood supply to the colon. And there's a lot of collateralization, as you can see, like even off the inferior sort of supplies the left side of the superior, the right side. But you can see there's blood vessels that branch off and sort of help collateralize. So if there is a blockage, the colon isn't going to get starved of blood. So what sort of symptoms are we going to see? So a lot of people complain of like postprandial abdominal pain. You're eating food, blood's going down to that gut to do its job. So usually within an hour or so of eating, they're going to get that pain, can last, a couple hours until food sort of is digested and sort of moving along in the intestinal tract. They've probably been complaining about this maybe for several weeks or months. I get this nagging eating. Maybe this does sound Crohn's-y, like people are sort of having pain after eating. Is there some inflammation going on in the small bowel? Some narrowings that are causing this, pain for them. They're going to probably feel full early because they're just like, oh, I eat and I'm not feeling really well. Weight loss is a huge thing here, up to 80%, because they're just not feeling well. They eat and they get symptoms. Very common with IBD as well, especially Crohn's patients. And some nausea and vomiting can also be seen in this patient population. Um, you know, IBD might not have pain with eating. Maybe your ulcerative colitis patients, not so much. Again, they're not having narrowing as much, but if they're having maybe a high fibrous diet and the colon is really red and irritated, they might have some abdominal pain. So a little tough to distinguish here between exactly what's going on. You just need more. And don't forget, again, ask about those extraintestinal manifestations. That could help, sort of thing. And I try to, people will say, yeah, I've been having these things. And then all of a sudden, my whole GI symptoms just went out of control. So if they're noticing these extraintestinal manifestations, before raging up at the same time, that's another piece of the puzzle. Again, history, history, history. Okay. Again, maybe you start doing some labs, they're having abdominal pain. So, with the white blood cell count, you can kind of see a little bit of a left shift. The CRP can be slightly elevated, ESR as well. Your B12, D, and iron should all be normal. There's no malabsorption going on here. That's getting blood supply, lesser to the colon, and then that's what's causing the pain is the ischemia, and then tissue can sort of get, inflamed and sort of actually start to, die off a little bit depending how bad the inflammation is. Calpro might be elevated given the sort of influx of white blood cells going to that colon. Again, some of these patients, depending how bad the presentation is, they could be in the ED. Like then you're going to look at lactates and CPKs and amylase, and that's going to start to show that lactate, the tissue damage, like there's really ischemic flow going on there, and they're not getting perfused. Also, PT-INR looking for clotting disorders, but all of these are really sort of non-specific sort of thing. And even endoscopy, most of it is kind of non-specific. You're going to see like gastritis, maybe duodenitis, even colitis, if you do approach it with EGD or colon. Although with EGD in the data, there's this gastric double stripe sign. It's like longitudinal ulcers on the anterior posterior walls. And these are kind of corresponding to sort of real areas like right near that gastric artery. So when that ischemia sort of happens, these ulcers form in a very sort of classic picture. So again, another piece of the puzzle there, along with the history you've taken. Pathology, if they do some biopsies, earlier stage, if it wasn't so bad, you might see the pathologies will comment on some hemorrhaging, maybe some edema, swelling of the tissue. If it was sort of a bad case, later case, they could see some necrotic tissue, ulceration of the mucosa, and the damage will actually get deeper into the tissue. So if you're thinking of, this, imaging, a CTA has like a 90% sensitivity and specificity. I mean, CTA is not the first thing most people, we do CTs, MREs, MRIs. Again, this is going to be sort of, it's going to might take you a little bit to get there. But again, I wanted to sort of, go over chronic mesenteric ischemia just because it has those sort of same similar symptoms of eating, abdominal pain, maybe some weight loss that's been going on. So can mimic there. Okay, celiac, probably definitely a much more common diagnosis that we've all seen. We're seeing this more and more definitely outside of the Caucasian European sort of population. It is a gluten-sensitive enteropathy, so it is doing some harm actually in the intestines. We're seeing more people with a gluten insensitivity, kind of like lactose intolerance, like they can eat the gluten, but they're not getting any sort of, inflammation and stuff. They just get the bad gas and bloating and diarrhea. So it is believed to be an immune-mediated inflammatory disease of the small bowel. Diagnosis age is roughly kind of in that same Crohn's IBD population or patient population, 10 to 40. There is definitely a genetic predisposition. It's a test we do order. Having a first and second degree relative predisposes one. Type 1 diabetes, as there's like commonalities and some genetic loci there. People with autoimmune thyroiditis also at a little bit more risk, and those with Down and Turner syndromes as well. Okay, symptoms of celiac, quite a whole host there. There's, diarrhea. People might say, hey, this is, very foul smelling, my stool sort of floating. A lot of bowel urgency, again, cramps. I guess it depends too on the gluten load they had, how much inflammation has already occurred, and how much malabsorption is going on. Definitely some weight loss, gas and bloating, fatigue, all kind of generic GI symptoms by themselves. People can get a little bit of a glossitis or even some oral lesions, and peripheral neuropathy. These are sort of the symptoms you're starting to get from malabsorption issues. B12, a lot of iron is all in that duodenum and the proximal jejunum where celiac does sort of do its damage. Even some vision issues, memory confusion, gait disturbance. And then in derm world too, there's dermatitis herpetiformis. People can get these rashes, usually like on the forearms, elbows, knees, and scalp kind of are the more common areas, but they can be in a few other areas. Differentiating symptoms. Again, they're having that diarrhea. They shouldn't be seeing blood though, at all. Again, if they're having a lot of bowel movements and it's I'll always ask, are you seeing just some trace on the tissue? Like, is this after your fifth bowel movement? Maybe some irritation on there, sort of thing. Abdominal pain probably, could be more severe in IBD if it's a little bit further down the line. As I've mentioned, if it's earlier on or the flare is not that bad, it could be a little minimal. So it's a little tough to distinguish sometimes just with symptoms. Some similarities here, as I mentioned, there could be some mouth sores, joint pain, skin rashes. So those extraintestinal manifestations here have a little bit of commonality with celiac as well, which is interesting. And again, they share a lot of, the malabsorption process is at play here in celiac, as we see definitely with our Crohn's disease patients. Okay, again, diarrhea, labs. CBC here is usually normal. With the CMP, we might see some elevated liver function tests. The CRP again, as we pretty much, I believe, all know, the CRP is a generic blood test that shows inflammation. And Dr. Law, who'll be speaking after me now, she actually taught me that there is a certain percentage, maybe 20% that might never even mount an abnormal CRP, even though inflammation is going on, which is good to know. And so we sometimes will really lean on that calprotectin test, which unfortunately takes more time, where the CRP you can get back in a couple hours if you need. Um, Vitamin D, B12, folate in a celiac patient, kind of like your Crohn's, are going to most likely be low because there's malabsorption going on in that small bowel. Iron studies as well can be quite anemic because that's where pretty much all of your iron is absorbed, is that duodenal, proximal jejunal area. Here, the serum IgA and IgA TTG, make sure you check that IgA because some people can be deficient. And, the TTG is usually the big, that's what will kind of give you the clue that there is some celiac going on. Calprotectin can be elevated, probably minimally. The calprotectin, we believe, the more proximal it is up on the GI tract, the more diluted it might get as it as things go along, the GI tract. So more of a raging ulcerative colitis, ulcerative proctitis, because we're at the most distal end, you're going to get a much higher sort of calprotectin result. So it could just be another piece of the puzzle. There's calprotectin smoldering, but the TTG will definitely probably be more the test to look for there. Stool culture obviously should be negative unless there's something else going on, but in celiac for sure. So this picture, again, it'll fit, you're asking them, they're eating gluten, etc. Endoscopy, EGD will be the sort of the first test. And then the person performing that EGD will see sort of this villus atrophy, sort of the villi just are like flattened, that architecture sort of gone. Just on a side note, they need to be eating about like 3 grams of gluten a day for about 2 weeks in order for it to sort of, do its damage, shall we say, so it can be visible. And then the pathology, there's, the villus atrophy can be seen. And then there's actually the Marsh criteria of like, how sort of blunted the villi have gotten here. I think it says type 2 to sort of the 3C or sort of supportive of the diagnosis. And type 4 might be a slam dunk. But again, it's one piece of the puzzle like they saw it. The TTG is positive, so you're putting everything together. And again, for imaging, you might not get that CT MRI as probably pain is not really present. They might have some noise in the stomach, some bloating and gas and discomfort, but maybe not really a pain where you might see in a very inflamed UC or a bad maybe terminal ileal Crohn's inflammation going on. But if there's been some weight loss, everyone presents a little differently. So each patient is approached differently. You might get some imaging, and I don't think it's going to be very specific to show much in terms of the celiac blunting there. Okay. Ooh, this one we could spend, a long amount of time on, IBS. And again, it's irritable bowel syndrome is some of, it's not irritable bowel disease, sort of irritable bowel or inflammatory bowel syndrome. So IBS, we believe it to be a functional disorder. It can sort of have a few different categories of constipation predominant, diarrhea predominant, mixed, where they flip back and forth and sort of they don't fall into really one category or the other too much. Definitely chronic abdominal pain, altered bowel habits. There's really no organic cause. It's sort of the diagnosis of sort of the end. You've like ruled everything out, everything else out, sorry. The pathophysiology is uncertain, but believed to be very multifactorial. Younger people definitely more prone than older. Female, again, more than male. And some of the data I saw, females are actually more constipation predominant overall. Some other associated conditions we'll see in the patient population with IBS: fibromyalgia, chronic fatigue, functional dyspepsia, depression, anxiety, somatization. So, a little bit of a mental health sort of questionnaire can definitely be a helpful thing. And we could see, some depression, et cetera, with the IBD patients as well. Okay. Symptoms again. We'll probably focus a little bit more on the diarrhea here because the constipation, probably not thinking as much UC, Crohn's disease. But the diarrhea workup again is going to be the same as we've discussed. But actually, some of the data shows that up to about 50% of people with IBS diarrhea predominant actually can see some mucus in the stool, which a lot of ulcerative colitis patients will mention. There could be urgency. There could be tenesmus. Again, if this is a very liquidy, stool, they've got to get to that toilet and they've emptied, but they still feel maybe they didn't completely evacuate sometimes. They can have some abdominal cramping for sure. It can be by itself, with or without the diarrhea. It waxes and wanes. A lot of association around bowel movements. They'll feel better from a pain perspective, cramping perspective after moving those bowels. A lot of emotional stress here. Meals can trigger this. The stress being another triggering factor, gas, bloating, and fatigue. Just a constellation of very generic sort of GI symptoms. Again, what can really differentiate this from our IBD population? We should not be seeing blood in the stool with IBS, again, unless it's a hemorrhoid or they've cleaned themselves up for the, fourth or fifth time. Um, Nocturnal bowels, we really shouldn't be seeing that. I always ask patients a lot, are you waking at night? Are your bowels waking you at night? Is pain waking you at night? If those are yes, then there's something a little bit bigger going on here. IBS really shouldn't be waking them up at night. Um, Maybe larger volume stool, maybe not as much in IBS. If they're having a bad ulcerative colitis flare too, that could be a lot of stool coming out of them because the colon's just not doing its job. It's not, reabsorbing water and everything's just kind of coming out of them. Or if they're not absorbing well from a Crohn's perspective, all of these nutrients, micronutrients make it to the colon. Colon does not know what to do with all of that. And it's like, get out of here, flushes water, and there you go with the diarrhea. Okay. Again, I won't spend a ton of time on all of this. There's like very specific Rome 4 criteria for looking at IBS, and like the abdominal pain component. It's got to be at least 1 day a week for 3 months, within the last 3 months, associated with two or more of the following: pain related to defecations, change in frequency, and change in the sort of the consistency. And the symptoms really need to be going on 6 months prior to diagnosis. Does everyone probably follow this to the letter of the law? Probably not, sort of thing. We've ruled lots of other things out by the time we've done that. Maybe it is close to 6 months. And there is, I assume most people have seen the fun Bristol stool scale chart. We have it on in every exam room. Some patients find it pretty hysterical, but it is very useful because it's funny how some people will have a different definition of diarrhea or constipation, and it kind of levels the playing field there. And I've included a little link here for the Rome criteria. So as you can see, like your type 1s, type 2s are definitely more on the constipation side. The 6, 7s tend to be a little bit more on the diarrhea predominant. And then your middle of the range here kind of seems to be the more normal. And then you can kind of ask, like, how often, what percent out of 100 are you having 50%, more constipated 1s and 2s? Or, how often are you having these 6 to 7s? So if it's 50% loose and 50% sort of hard and lumpy, you're kind of in this, IBS mixed, and then you can fall anywhere on the spectrum, obviously, depending what the patient is telling you here. So that's, the way to, look at your IBS. Again, if they're really presenting with diarrhea, you're going to do your lab workup, of course. CBC should be normal. CMP should be pretty normal. They shouldn't really be pooping that much to really be getting dehydrated where they can't keep up with it. CRP, ESR should really be normal. Celiac you'll probably do as well, hopefully, if you're thinking diarrhea and you're leading towards that pathway. Calprotectin should definitely be normal. Stool culture should be normal. Normal. Again, this is a functional sort of process, and all of these tests really don't gonna not lead, but it gives you some information for sure that there isn't really anything pathologic going on. Endoscopy. Probably not thinking about endoscopy, only if maybe some alarm signs are sort of present, or if they're over 50 here, we're seeing bright red blood per rectum. It's tough. That's one to tease out, bright red blood. It's always sometimes good to err on the side of, caution and be like, maybe it is internal hemorrhoids. Maybe it is something a little more insidious. So maybe we should look and just rule out, some more causes that could be a little more concerning to us than just an internal hemorrhoid. Um, if there's progressive pain, weight loss, and there's other sort of abnormalities in labs showing malabsorption sort of thing or inflammation going on there. Some of the testing, in GI, probably more so if it's constipation, we'll do a GI motility, anal rectal manometry if they're having trouble sort of defecating, sitz mark studies if we think there's slow transit for constipation. Then imaging, obviously, really won't show anything because there's no inflammation going on. There's nothing really to see here in that sense. Sometimes, again, if we're thinking more of the constipation side, that KUB, can show some sort of stool burden. We've seen patients who have like overflow diarrhea. They've got a lot of stool buildup and they try taking some laxatives and then they get sort of like an overflow diarrhea, but they really need a full clean out. But imaging, we're usually not thinking about, it's sort of in an IBS sort of population. Okay. Diverticulitis, technically diverticulosis until it becomes inflamed. Lots of people always say I have diverticulitis. My mom loves to go around and tell all her friends she has diverticulitis. And I'm like, I hope you don't have diverticulitis because you should probably be seeing someone. But anyway, it is, I jokingly tell most patients they are the potholes or the cubby holes of the colon. And they can become inflamed. And that's when the diverticulitis obviously becomes the issue. Again, this is a diagnosis we see a little bit later in life. Again, doesn't really fit with the 15 to 30-year-old IBD sort of population. Only 20% of people under the age of 40. And then 60% of people over 60 is what we're really seeing. And males, now the males finally are outnumbering the females in terms of diverticulitis. And only 4% of people, data show, get diverticulitis from their diverticulosis. And there's uncomplicated and complicated cases. And just as an FYI, a lot of patients just still ask, like, oh, I shouldn't be eating seeds nuts. Big, enormous study, debunked all of that. But if people feel like, oh, I eat popcorn, every time I eat popcorn, I get it, please avoid popcorn. You know yourself better than I do, but technically, we don't like to deprive people if they don't, have to, if they really like certain foods. Okay, what sort of symptoms are we seeing with, diverticulitis, especially the first time? If people have had a bout or two of this, they kind of know, oh, I think it's a diverticulitis again. Abdominal pain. Most the diverticulae are in sort of that sigmoidish area. They can be anywhere technically, but the average tend to be a little more left-sided. So you'll kind of have a more focal left-sided pain. And sort of the real classic symptoms are also the nausea, vomiting, some low-grade fevers, just feeling kind of ugh, from a GI perspective. Constipation can actually happen in about up to 50% of people, and diarrhea 25 to 35%, or just, the remaining, percentage just kind of normal, still just having these other symptoms. Blood and stool. In an actual like diverticulitis, we almost never see blood. At all. A diverticulum itself that is not inflamed can bleed. It's usually a painless bleeding, and then they've just got bright red blood per rectum, and then you're chasing that down. Usually, then you've got a colonoscopy. Then you'll see that they have, diverticulosis throughout, though. But the bleeds can usually be pretty quick and self-limited. In my many, many years here in GI, I've only seen maybe 2 active diverticular bleeds, and usually someone's in the endoscopy unit yelling, "I've got an active bleed," because by the time you prep and get ready for it, that bleed stops. So it's pretty rare to catch an actual bleed. Okay. Labs, you might see an elevated white blood cell count because there's some infection going on there. Your CMP normal, the CRP again, there's some inflammation, might be a little mildly elevated. Calprotectin might be elevated, depending on how, how big the inflammation or how, much inflammation is going on. Stool culture, etc., should be really normal. Endoscopy for diverticulitis is really, we only do 6 to 8 weeks after that first episode, just to ensure there's no malignancy or cancer going on there. Imaging's usually, most people present with some pretty, good pain. They'll wind up in the emergency room that first time. The CAT scan will probably show the wall thickening, inflammation, even some fluid collection, pericolonic fat stranding. And again, the sigmoid colon, that left side, is really the more common. Again, how severe that flare is, and if it's a more complicated case, we will see these things, and it can be, we can see abscesses, perforations, even obstruction, because the inflammation just gets so big, the lumen of the colon is just, closed off, and we can even see some fistulization as well. Okay, I think the last one, hopefully I still have a minute or two. The immune checkpoint inhibitor colitis, we're seeing it a lot from our oncology colleagues. It is, so you might hear it as, immune therapy induced colitis. So people are on these immunotherapies for their cancer, and, it can start to cause a bad diarrhea. And this is just sort of a real watery diarrhea with a frequency above their baseline sort of thing. It just really ramps up really quickly. And it usually starts like a few weeks or months after the initiation of therapy. So they're on their, way down for a few weeks, and then all of a sudden it hits and they're not thinking that could be like, what's going on? I thought I would have had the diarrhea earlier on there. So this colitis is a very watery diarrhea. You can have abdominal pain, fever, mucus, bloody stool that they'll see. Um, Real quick, there is a grading system for the diarrhea. It goes 1 through 5, the mild, moderate, severe, and you're kind of borderline hospitalization. I hate to say death is actually on that scale. If you're at sort of like 2 plus, they're going in for colonoscopies. And I really should say probably flexible sigmoidoscopy. I should correct that because there's a huge risk for perforation. Because if you know this is an oncology patient, they're on an immunotherapy, and this diarrhea starts like a few weeks into it, you're kind of got all of your ducks in a row there. You know what's going on. And the colitis has a grading system as well that can, go from pretty asymptomatic all the way up to death as well. Okay. And lastly, for labs for this, you're doing labs and, you're sorting through these labs and you're thinking all different pathways here. What could this be based on my history and putting that puzzle together? That's why I think that's the exciting art part of medicine is just putting all of these pieces together and figuring out what's going on. The CMP most likely could be, maybe I should edit that. I mean, if they're really profusely having some diarrhea, there could be some signs of dehydration there. The CRP again, elevated calprotectin, usually quite elevated. Stool culture should be normal unless they have some sort of, underlying infection because of, being immunocompromised from other oncologic treatment. Um, so the flex sig, as I had mentioned, regardless of calprotectin, they really need to look at the severity of what's going on. Do they need to, can they continue treatment? Do they need to stop it or whatnot? Findings, though, can be non-specific. This could look like a really bad ulcerative colitis. And we used to use high dose steroids in the day, but now we'll use your Remicades and infliximabs to really knock this inflammation down. CMV can also be seen in some cases as well. And then on pathology, the pathologist will tell you they're going to see a neutrophil and or eosinophilic infiltration, some epithelial apoptosis, cryptitis, and crypt abscesses. Again, you might not even need that pathology report. You kind of know the picture because there's a very specific population. I just wanted to add it on here because it really can mimic sort of an ulcerative colitis. And we do use a lot of the same medication there. Imaging, if they're coming in with this, if they're having fever, abdominal pain, and they might be bloated going on, the CT is going to definitely show, the colitis wall thickening, mucosal hyperenhancement, could be diffuse, could be segmental, kind of maybe look like a Crohn's-y sort of picture, but again, you have a lot of other information in your back pocket by the time you get to this point to really think that this is an ICI sort of colitis. And I think that is the end. I just want people to remember, with differentials, we could have spent a week on this topic. It could be so many different things, but just remember, there is no single lab value, radiology, endoscopy, or histology finding that makes a diagnosis of IBD. It takes a lot. You're going to use your labs and all of the data there. Am I seeing signs of malabsorption? Am I seeing signs of infection? Is radiology showing me signs of inflammation, strictures, abscesses, fistulas? Endoscopy as well. You're going to see that in, with our partners in pathology. Granulomas, I'm sure we probably touched on that earlier. It's a very sort of hallmark sign of Crohn's disease is a biopsy with granulomas seen. That's what can really help the diagnosis there. And then some references that are there. And then I think that is the end.